Lifesavers, and welcome back to my channel. My name is Nurse Kelly Tyrell, and in today's video we are going to be starting our mini series on the endocrine system. So we're going to learn a little bit about how the endocrine system works, and then we're going to talk about two common endocrine disorders, diabetes insipidus and SIADH. But before we jump into it, make sure you subscribe to my channel, like, comment, and share this video with a friend, and make sure you click that bell icon to turn on notifications so you don't miss out on my upcoming content. If you have trouble identifying hallmark signs and symptoms and spotting differences between endocrine disorders, then I suggest you keep watching. Okay, so let's talk about anatomy. So the endocrine system is made up of several glands that are spread all throughout your entire body. And the primary role of these glands are to release hormones and chemical messengers which regulate the activity of cells and hormones in the blood. So the endocrine system influences things in the body like growth and development, digestion, regulation of metabolism, and it plays a key role in reproduction. So hormones from the endocrine system are released into the bloodstream due to some kind of stimulus or another hormone within the bloodstream. So for example, if there's a rise in glucose in the bloodstream, then the endocrine system will send signals to the pancreas and tell it to secrete more insulin in order to lower the blood glucose levels. So how does your body know when to shut off these signals? Well, that actually happens through a process called direct feedback. So direct feedback is needed to maintain homeostasis or equilibrium inside our bodies. So in a nutshell, the body receives feedback about changes in hormone levels, which triggers organs and other body systems to adjust to the hormone production, so that way it can return the body back to that homeostasis level. So when the concentration of the substance reaches a certain threshold, like insulin secretion to lower the blood sugar, once that threshold is reached, the gland and its production of hormones are turned off. When there's a breakdown in that direct feedback process and the gland doesn't turn on or shut off, that's when you have diseases like SIADH, thyroid disorders, and diabetes, for example. So the major gland found within the endocrine system is very common. It's known as the thyroid gland. And that's located in the anterior or front part of the neck overlying the trachea. The thyroid gland produces three key hormones. So you have T4 or thyroxine, T3 or triiodothyronine, and calcitonin, which affects the blood calcium and phosphate release from the bones. So the thyroid hormones affect many things in our bodies, including metabolism, muscle composition, the heart, and they play many other smaller roles in other organs and body systems. You also have the anterior pituitary glands within the endocrine system, which are controlled by hormones from the hypothalamus through that direct feedback process that we just talked about. The anterior pituitary gland hormones are primarily responsible for the regulation of the reproductive system, and the anterior pituitary secretes 6 major hormones that you want to be familiar with. So thyroid stimulating hormone, or TSH, follicle stimulating hormone, or FSH, luteinizing hormone, or LH, the growth hormone, prolactin, and adrenocorticotropic hormone. You also have a posterior pituitary gland which produces the hormones oxytocin and vasopressin. Okay, so let's talk about other major glands in the endocrine system, which include the adrenal glands, and they actually sit on the top of each of the kidneys. And the adrenal glands are made up of 2 parts. So you have the cortex, and then you have the adrenal medulla. So let's talk about the cortex first. So the adrenal cortex secretes 3 major hormones. So the first hormone is aldosterone. And this is responsible for the reabsorption of sodium and then the excretion of potassium through the kidneys. The second hormone is cortisol, which helps to maintain glucose control through a process called gluconeogenesis in the liver, which is basically a fancy term for the making of glucose. Cortisol also plays a major role in that fight or flight stress response. And then the third hormone that the cortex secretes is androgens and testosterone, which are known as the sex hormones. So too much of this hormone in women will result in dark facial hair, acne, and infertility, and not enough of it in men can result in hair loss and also infertility. So now let's move on to the adrenal medulla. So the adrenal medulla produces and stores and secretes two major hormones, and that is the peptides and two different catecholamines, which is known as epinephrine and norepinephrine. So these hormones are our natural stimulants. So when they're released, the heart rate and respiratory rate increases, the blood pressure rises, the airway dilates, and the metabolic rate increases because your body is working in overdrive from those natural stimulants circulating through your bloodstream. And the last major gland we're going to talk about in the endocrine system is the parathyroid glands. So the parathyroid glands are made up of 4 to 6 smaller glands, and they're located on the posterior, that means behind the thyroid gland. The parathyroid glands produce the parathyroid hormone, or PTH, which helps to maintain that calcium and phosphorus levels that you have circulating in your blood. So if the calcium level falls, then the parathyroid hormone is released, which causes your bones to break down and then release calcium into the bloodstream. It also sends signals to the kidneys to decrease the calcium excreted through the urine, which in turn will increase the phosphate excretion. So when this happens too often, you develop a very common bone disease called osteoporosis, because the parathyroid hormone is telling your bones to release all of that calcium to compensate for the low calcium blood levels. So when you lose calcium in your bones, they become very weak and they become brittle. Okay, so now that you have an understanding of how the endocrine system works, let's talk about what happens when things go wrong. So the first endocrine disorder we are going to cover is diabetes insipidus, which is not to be confused with diabetes mellitus. They are two very different conditions, and that is going to be a whole separate video coming out next week. So the hypothalamus produces a hormone called ADH, or the antidiuretic hormone. And this hormone helps your kidneys to manage the amount of water and electrolytes within your body. So ADH is produced in the hypothalamus, and then it's stored in that pituitary gland. When there's not enough production of ADH, or the pituitary gland doesn't release enough of that ADH, it affects the ability of the kidneys to be able to concentrate urine. So why is this a bad thing? Well, it's bad because the kidneys then start producing large amounts of very diluted urine, and you start retaining large amounts of electrolytes like sodium and chloride in the bloodstream. So patients presenting with symptoms of diabetes insipidus will often be drinking large amounts of water to try to compensate for the excessive urine that they're losing, but they will still be extremely dehydrated according to their lab values because the kidneys are allowing all of that water to pass through, but they start losing their ability to filter out the buildup of sodium and chloride from the bloodstream. And remember, water always follows sodium. So as the sodium levels rise in the blood, all of the water from the organs and cells within the body start entering into the bloodstream, which makes the patient extremely dehydrated, even though they're drinking a ton of water. So why does something like this happen? Well, the primary reasons that a patient may develop diabetes insipidus is typically from damage or injury to the hypothalamus from things like a tumor or head trauma or sometimes even infection. Another reason a patient may develop diabetes insipidus is from extremely elevated calcium levels, which can sometimes be seen in patients who have lithium toxicity. Okay, so now let's talk about some hallmark signs and symptoms and some test results that you're going to run. So the classic signs and symptoms that you're going to look out for is a significantly increased volume of urine that is really, really diluted. So the urine is going to be really pale or colorless, and it's going to be odorless because remember, it's not going to be concentrated with the normal toxins and extra electrolytes that cause the urine to be yellow and have that odor. And then the second classic symptom is going to be excessive thirst, which is also known as polydipsia. The body is going to try and replace all of that volume loss by sending out those thirst signals. And an easy mnemonic that you can use to remember diabetes insipidus is the 4 Ds. So you have decreased ADH, dehydration, dangerously high sodium and chloride, and dilute urine. So as far as test results, these patients are going to have a normal blood glucose level, because remember, diabetes insipidus and diabetes mellitus are two completely different issues. You're also going to see a really low specific gravity in the urine, because the urine is produced in large volumes and it's extremely diluted, so it's not concentrated at all. Another test result will be an increased BUN, which typically indicates dehydration and that your kidneys are starting to feel a little stress. You will also see electrolyte imbalances, because as the kidneys fail to excrete that sodium and chloride in the urine, they will begin to retain and rise within the bloodstream. Now let's talk about two important tests that you'll want to be familiar with when you're trying to rule out diabetes insipidus. So the first test is going to be a water deprivation test. So in order to perform the water deprivation test, you're going to ask the patient to withhold all water intake for several hours. And if the urine production continues to increase, then the chances are the patient is likely experiencing diabetes insipidus. Now, I will say this test is not obviously used in critically ill patients, because it takes several hours, and usually patients who have diabetes insipidus are really, really sick and they need a diagnosis and treatment ASAP. The next test that gives you a quicker result is the vasopressin test. So basically you administer a small dose of vasopressin through an IV, which is a synthetic form of the ADH hormone. If the dose of vasopressin decreases the urine output and the specific gravity increases, then that means that the test is positive and diabetes insipidus is really, really likely. Which makes sense, right? Because remember the 4 Ds. So the first D is for decreased ADH. So if you're supplementing with a synthetic version of ADH, then the patient improves, and that would confirm that there's a deficiency in natural ADH within the bloodstream. And the last test that you'll likely see with a suspected case of diabetes insipidus is a brain MRI to check for any tumors on the pituitary gland or the hypothalamus. Okay, so what treatments can you anticipate when your patient is actually diagnosed with diabetes insipidus? Well, you can expect to continue giving vasopressin or desmopressin until the patient's urine actually starts to decrease. You'll also give a diuretic called hydrochlorothiazide, which I know what you're thinking, why the heck would I give a diuretic to a dehydrated patient who has excessive urine volume? But the HCTG actually produces what we call a paradoxical or an opposite effect when the patient has diabetes insipidus. So the reason this happens is still a little unclear, but the theory is that the HCTZ increases the concentration of sodium and chloride in the kidneys, so it actually draws out the sodium and chloride from the blood and back into the kidney so it can be filtered out through the urine. Other treatments will include placing the patient on a low sodium diet, because obviously we want to reduce the sodium levels in the blood and increase the patient's fluid intake. And lastly, some nursing interventions you'll want to implement will be to monitor intake and output very closely. You want to continue to monitor for signs of dehydration, fluid and electrolyte imbalances. And you also want to make sure that you weigh the patient every day. And you want to do this at the same time in order to monitor for excessive fluid loss or fluid retention. All right, so now let's talk about SIADH, which is the literal quite opposite of diabetes insipidus. So unlike diabetes insipidus, which is from a decrease in the antidiuretic hormone, the syndrome of inappropriate secretion of ADH is caused by too much of the ADH being secreted by the posterior pituitary gland. So now remember I said that ADH is responsible for controlling the amount of water that's reabsorbed by the kidneys by preventing the loss of too much water. So typically when you have too much water in the body, the ADH secretion decreases, which allows for your kidneys to filter out that excess water. But when your pituitary gland fails to recognize when there's too much water and it keeps producing large amounts of the antidiuretic hormone, you develop the condition called SIADH. So what causes this condition? Well, it can be caused by a number of factors, but the most common ones are damage to the hypothalamus or pituitary gland, whether that be from some kind of head trauma or infection, inflammation, or tumors. Some medications like SSRIs, carbamazine, cyclophosphamide, and chloropropamides can cause this condition as well. Also, certain types of cancer, especially small cell carcinoma of the lungs, can trigger an increase in ADH production. Prognosis for patients who develop SIADH is actually really great if the sodium levels are kept within normal limits. So next, let's talk about the hallmark signs and symptoms of SIADH. So you're going to see basically opposite effects than what I talked about with diabetes insipidus. So you're going to see things like elevated ADH. You'll also see very low levels of serum sodium in the blood called hyponatremia with SIADH. But with diabetes insipidus, you'll see elevated levels of sodium. And that's because with SIADH, the kidneys are holding onto the water, but they are still filtering out the sodium from the bloodstream. So you'll also see a urine sodium level of greater than 20 MEQs per liter. You'll also see low urine output, which is called oliguria, and that is significantly concentrated, which again is the opposite of polyuria and diluted urine that I talked about with diabetes insipidus. And the BUN and creatinine levels will be low to normal, which again is the opposite from diabetes insipidus. Some other hallmark symptoms that you'll see are headaches, nausea, vomiting, confusion, personality changes, coma, and seizures, all because of that significant hyponatremia. Sodium plays a huge role in water and electrolyte imbalance, and it affects the nervous system. So it's really important to bring these sodium levels back to normal as soon as humanly possible. The main treatments for SIADH are going to be fluid restriction and to treat the underlying cause. Now, I know I just said that these patients have a really low urine output, so why would we restrict fluids? Well, it's because they are still producing large amounts of fluids that is being stored in the bloodstream. So what happens is it actually causes severe dilution in the vascular system or the bloodstream, which is why these sodium levels drop so much. But unlike diabetes insipidus, where it causes that severe dilution in the urine. And as far as nursing interventions go, again, you're going to monitor electrolytes and sodium levels very carefully through frequent blood work. You'll also restrict fluids because, again, the excess fluid in the bloodstream dilutes the sodium levels. You'll also want to weigh the patient daily at the same time each day and monitor the intake and output, again, to assess for any excessive fluid loss or retention. So hopefully now you can spot the key differences between both of these common endocrine disorders, and make sure that you tune in tomorrow because I'm going to be covering 2 more common endocrine disorders that most of my students often get confused, which is Addison's disease versus Cushing's disease. And that concludes the end of this lesson. I hope that you found this information extremely valuable and it made you just a little more confident as you prepare to take your NCLEX or your next nursing school exam. I just want to thank you all again so much, Lifesavers, for tuning in today. My name is Nurse Kelly Tyrell, and I help nurses feel more confident, increase their test scores, and retain what they don't remember in nursing school. Speaking of, are you a nursing student or soon to be or ready to take your NCLEX? If so, have you joined my online student community yet? If not, then what are you waiting for? The University community is a complete nursing resource hub all at your fingertips. Inside, you can expect to receive coaching, community, and content. You'll get daily coaching with your mobile mentor, me, Nurse Kelly Tyrell. You'll also receive access to weekly educational videos that you can watch months before they even publish to YouTube. You'll also get exclusive printable digital downloads like worksheets, quizzes, flashcards, infographics, cheat sheets, skills checklists, and more. And if this video helped you in any way, be sure to give it a thumbs up. Also, don't forget to smash that subscribe button and click that notification bell so you don't miss out on my upcoming content. Also, if you can do me a favor and drop me a comment below. Let me know where you're at with your nursing journey. I'd love to just say hi and connect with you. Also, make sure you click that share icon to spread the word and encourage a fellow aspiring nurse. And last but not least, when you are ready to take your NCLEX, be sure to check out my NCLEX and Chill review, where I review detailed test-taking strategies and cover every major topic that you can expect to find on the NCLEX. If you want to have that unfair advantage and pass your NCLEX on your very next attempt, be sure to click the link in the description box below. Not ready to end the study sesh yet? Well, you are in luck, because if you stick around, you can watch more of my videos coming at you in 3, 2, 1. Bye, lifesavers.